Next speaker is Dr. DEEPAK MISHRA. He is going to talk about the role of lasers in advanced glaucoma.
It's okay. Thank you. Thank you, ma'am, for including me in your IC. And good morning and warm welcome to all of you. There is no financial interest. We all discuss whatever the modalities are there and why surgical, why medical, and why lasers. These are the three things which is important in the management of the glaucoma. And since you have seen a huge market, just ma'am told us that how these markets affects the economy of the patient and everything. For that, we can have something in our treatment box, that is the lasers. Lasers have many uses and few indications are helpful for the community to reduce the economic burdens, for increase of the compliance if patient is coming from remote and not coming to you every time. And important one is, it is actually an adjuvant or an alternative therapy. It is not anywhere indicated as a first line therapy. It may be combined with drugs or surgeries or some in cases of prophylactic. So I'm skipping these slides about the laser, and there are the various sources of lasers and the wavelength you can find out. They can be solid or liquid lasers and have different wavelengths for that. And these are the three possible mechanisms by which a laser can act. This is not, we can use each and everywhere. But here is in advanced glaucoma, we have 3-4 different options. Most important is where is a chances of you suspect as a clinician for the internal block, then which type of laser you used, and when there is a chances of outflow obstruction, then which type of lasers are used. We mainly concentrate on these two different internal and outflow obstruction, and there is some also miscellaneous uses, not for here, but some in cases of advanced glaucoma, if there is chances of removing suture or anything, you can also use. But we concentrate only on these two aspects. Now the laser PI. This can be done with the argon laser, and these are the various conditions in which we can use it in acute angle closure glaucoma or the chronic. It is, we can say it is almost the most common type of indications for using lasers in the glaucoma. And the basic mechanism behind this is it requires energy that it works on the principles of the photo disruption. So whatever we can give, it just coagulate the tissue and make an alternative pathway for the drainage. We can do it by argon laser or Nd:YAG laser. I just put this slide here for someone who is practicing, or for the residents. They have asked mostly these questions: what are the different parameters used in the argon laser and the Nd:YAG laser? Because in the laser, parameters are of much more important. Then before doing, you must know how your machine is behave and what parameters to be set to make it more and more effective and comfortable. So, and these are the common problems or the error that occur during the LPI. One of the common is that iridotomy is not patent, and what our teacher says, our book says, that whenever you have done the laser PI, first of all, you can see a sudden gush of aqueous coming from it. There is change in the anterior angle chamber, and most important, in cases of advanced glaucoma, even you can, if do the gonioscopy before and after laser, you can find out what are the changes and how these angles behave just after putting 3 or 4 slots on the laser. Now, the laser for the advanced open angle glaucoma option is the ALT, and ALT works on slightly different mechanism, that it helps in the stretching of the trabecular meshwork and clean the debris from the network too. And this is, SLT is something said to be a much more advanced and better because it works and useful in cases of failed ALT or whatever. Just Professor Vyasar said that most of the vision threatening causes includes the secondary glaucoma like pigmentary or the pseudoexfoliation, and these SLT is supposed to be better for it. Here you can see in the SLT we target only the melanin component of the trabecular meshwork, or which is the pigmented one, and this have something different mechanism. It works on the basically the release of these cytokinins, and these cytokinins works on the endothelial layers and the trabecular meshwork. Another one is MLT, that is the micropulse laser trabeculectomy. Here you have seen, and this is a slide which shows very important to show all the differences between ALT, SLT and MLT. But what we can find out advantage of SLT and MLT is you can theoretically repeat it and even the practically repeat it, but for ALT repetition is not possible. And second one is the thermal damage. The thermal damage, or this is only SLT is a selective destruction of pigmentation, and it is not the selective. It is a whole soul burning of whole thermal. And in MDLT, thermal defect is very less. I am seeing you the electron microscopic picture of the trabecular meshwork. Just after ALT, you have seen how much structurally it disturbed, and with the micropulse laser technique, how the anatomy is also the maintained during it. Cyclodestructive procedures just leads to lot of hypotony and different thing, but for a cases or places where these facilities are not available and there is some emergency or something you can do, or better, we request you to not do it so commonly and refer the patient to the available options where is the available. And laser sclerotomy can be done for some cases if it is available in a good center, and usually the failed cases and multiple surgeries, everything. And this is the laser setting for the all types of glaucoma procedure. If anyone is wish to do, at least remember three things: what will be the spot size, what is the duration, and what is the power of your laser. These three things I have tabulated in all the things for NDR, PI, or the photo disruption, or the suture diagnosis. Anything you want to do with laser, at least have the snapshot of this slide to save or put it onto your table so that your fellows and residents are much more comfortable, and never for just like a checklist we put it every time we give intravitreal injection, but again in most of the OTs we put it to have some intravitreal list. Similarly, this is the list for the lasers. Whatever the setting is important, and you have to know all the settings in the laser. With this, I can conclude that lasers, as ma'am said, is also a very important in the management of the advanced glaucoma, and useful in cases of when we can add on for the medical or the surgical treatment too. And with this note, I would like to thank you. Thank you, sir.
Thank you, Dr. Mishra, for excellent talk on laser. A few comments on the laser is that ALT, SLT or MLT are the treatment modalities in the advanced glaucoma, specifically advanced glaucoma has a very limited role. And especially these type of lasers are not very effective in Indian eyes, but even then one can do it on very, very certain specific situations temporarily, because the effect remains only for 2 to 3 months to 4 months. Say for example, a clinically young lady has got advanced glaucoma, and you cannot give any medication for a child, the baby will be affected. So if you are not prescribing any medication, what is alternative? So you can resort to SLT or even ALT, which is still not performer in Indian situation, or even MLT temporarily for such patients. Second is patient is not agreeing for this surgery and your target pressure is not achieved. then you think of doing something so that you buy little time, maybe few months, till the patient and the relatives decide for the surgeries. If you have got the best option of any surgery which is more predictable with endolaser cyclophotocoagulation. So if you can, you have that facilities, or you refer the patient to those facilities where the surgeon, which is a little more trained and maybe in association with the retina man, he can do endolaser cyclophotocoagulation. That will be more predictable, and that will be most ideal where the target pressure is not achieved with the medication and the patient is reluctant for the surgeries, or in spite of the surgery, the progression is still there, whatever may be the reason. So in such situations, one can go for endolaser cyclophotocoagulation, which is more predictably, you see the ciliary body processes and you burn them and see that they are destroyed and has shrunken. So that